Hello, this is Andrew Wolf. In this video I'm going to talk about the physiology of the exocrine pancreas and a little bit about pancreatitis. So the pancreas is a small organ, about 10 to 15 centimeters long in the epigastric area in the retroperitoneal space, and it's sort of tucked in the curve of the duodenum as the duodenum sort of makes its way from the stomach down to the jejunum. So we have the stomach up here, and the pancreas, within the middle of the pancreas, is a relatively large duct. It's 3 or 4 millimeters thick, which runs the length of the pancreas from the head of the pancreas to the tail. And this duct, I've heard it called, the formal name for it is the duct of Wirsung, and I've also seen it called in many textbooks the main pancreatic duct. Now, the pancreatic duct drains into the duodenum at the ampulla of Vater. Now, in about half of people, the gallbladder meets and forms a common duct, the common bile duct, just prior to the ampulla of Vater, and they drain into the duodenum together. However, there are a number of people that have the bile duct actually draining separately, right next to the common bile, to the main pancreatic duct, or the duct of Wirsung. So there are variations here, and also about a third of individuals have a second drainage duct called the accessory duct, or the accessory pancreatic duct, and the formal name for this is the duct of Santorini. And I believe it's about 30% of people have this accessory duct. And it's nice if you have one, because you're less likely to get gallstone pancreatitis if you do, because you've got a secondary way of draining your pancreas. Okay, now all along this duct of Wirsung, we have little branches of the duct, and these little branches branch out into acini. And these acini are surrounded by little areas of sort of grape-like clusters of acini cells, and it's these acini cells that have that secrete pancreatic juices. Okay, now intermixed within here, and it's interesting to think about the evolution of the pancreas. I'll just talk about it a little bit here. The pancreas actually buds off of the embryonic tube that becomes our small bowel, and it actually forms, early on it forms two little buds, and these two little buds eventually fuse together to become what is later the pancreas. And it's the fact that there are the two little buds here that give rise to this accessory tract, this accessory duct, because this accessory duct is sort of a remnant of this original two bud conformation. Now, as the pancreas grows, initially it only has epithelial cells that are similar to the enterocytes that are growing, that are starting to mature inside the tube of the GI tract. But it starts to get populated by neuroendocrine cells that sort of mobilize there from other places in the body. And these neuroendocrine cells populate small little clusters of cells that later become the islets of Langerhans. So these develop from a whole different cell line than the Acini cells in the pancreas. And they happen to share the space of the Acini cells, but they have a totally different lineage. And we talked about the islets of Langerhans in the endocrine section. So we're not going to talk about it here. In this discussion, we're really focusing on the Acini cells of the exocrine pancreas. Okay, so let's take a little close-up view here of one of these Acini. So here we have draining into the duct of Wirsung, and we've got this grape-like configuration of Acini cells. They're actually sort of triangular shaped, and that just allows them to fit around in a circle. And they're very easy to note on pathology slides because they have these collection of little granules in them. And these little granules are called zymogen. And what are they? They're little lysosomes filled with enzymes. So let's talk about the makeup of the juices that are secreted by the Acini. First of all, there's a lot of water, and that water contains a lot of bicarbonate. In fact, pancreatic fluid contains about 150 milliequivalents per liter. And this 150 milliequivalents a liter compares to about 23 to 24 in normal plasma. So it's about 6 times the amount of bicarbonate in plasma, and it gives the pancreatic juices a pH of around 8.4. And this pH of 8.4 neutralizes the acids in the stomach so that it becomes slightly, the contents of the duodenum becomes slightly alkalotic to around 7.5. And that is coming from the stomach where the pH is, pH is down near 1. Okay, what else is in pancreatic juices from the Acini? There are some other electrolytes, but bicarbonate is the main electrolyte, or at least is the main anion. The main cation is going to be sodium, although there is some potassium as well. And the only reason that these are here is because we have to respect the laws of electrical neutrality. It has to be a neutral solution. Now, the other things that are in here are the enzymes. Now, there are lipases that break down complex lipid molecules. There are amylases that cleave starches down into more simple sugar. And then there are proteases. Now, the lipases and amylases are generally already in active form. The proteases, however, are pro-proteases. They are stored in an inactive form. And then the other enzyme that is released in the Acini is trypsinogen. Now, when trypsinogen, what happens? Well, let me move up here and we'll talk about what happens in the small bowel. So here we have a whole bunch of proproteases that are secreted into the bowel. And we also have trypsinogen. Now, trypsinogen is activated by what are called brush border enzymes. And trypsinogen, so what we have here is some of the enterocytes inside the duodenum activate trypsinogen and turn it into trypsin. So we have trypsinogen getting changed into trypsin. And this is occurring because of brush border enzymes. Now, the trypsin goes on to activate the proteases. And this only happens, at least in a healthy individual, this only happens inside the duodenum. So this is a protective mechanism, because if we had activated proteases inside the acini, we would have a lot of significant problems, because we would start to break down proteins within the acini themselves. Okay, and that brings me to my discussion of pancreatitis. Because it really is a problem that is caused by enzymes that begin to break down and autolyse cells inside the pancreas. So let's talk about how that can occur. There are two major causes of pancreatitis in this country. Actually, we can break it down like this. Pancreatitis, in this country, about 65% is caused by alcohol abuse. And about 20% is caused by gallstones. Now the remaining 15 is caused by, another sort of miscellaneous group of drug use, toxins. There are some like scorpion bites that can cause it, and some other toxins, viral infections. And of course trauma. And the trauma, could be from a gunshot wound, or it could be iatrogenic from surgery. Okay, and so, this is a fairly complex and diverse group, and I'm not going to get into it here, although one of the more interesting cases of acute pancreatitis, where I had a very, very sick kid, was actually due to cocaine abuse. But this is actually relatively rare. There's lots of people that use cocaine that never develop pancreatitis. So I'm going to focus on the alcohol abuse and the gallstone pancreatitis. So gallstone pancreatitis begins obviously with gallstones, and actually, a significant portion of gallstone pancreatitis is actually from what are called microlithiasis. So you actually can't see the stones. They're microscopic, but what they do is they cause hyperviscosity in the common bile duct. And whether it is a one big stone that blocks it off, or just sludge that blocks it off, you get blockage of the common bile duct. So pancreatic secretions cannot be secreted. Now the other cause, so you get blockage of the common bile duct. Now alcohol abuse causes pancreatitis. Actually, there's a number of different theories. One is that it actually slows down peristalsis of the common pancreatic duct and causes a functional obstruction. Another is that it actually, chronic alcohol abuse creates changes that stimulate, or activate, I should say, activate trypsinogen. Okay, so and there's actually a few other theories as well. And I think that alcohol pancreatitis is actually a fairly complex physiology that probably involves a number of different mechanisms. But whether it's caused by blockage, by physical blockage, functional obstruction, or initiation of trypsinogen, the effects end up being the same. Once pancreatitis starts, you end up with a downward spiral or a positive feedback loop that just makes the situation get worse and worse. Now, blockage, functional blockage or physical blockage, causes inflammation within the acini. Here, let me use a different color here. And this inflammation activates, can lead to a cascade that ends with the activation of trypsinogen. Now, the activation of trypsinogen turns to trypsin, and trypsin activates proteases within the cell. And when you have proteases activated within the cell, you start to break down proteins within the cell. It ends up causing cell lysis, and cell lysis causes more inflammation. And the more inflammation we have, the more trypsinogen we have activated, and we end up with the positive feedback loop that I talked about here. Now, typically, this is a self-limited disease, and about 75 to 80% of acute pancreatitis is mild and self-limited. And the theory is that it's only involving a part of the pancreas, and before the situation gets totally out of control, the body, remember the end stage of acute inflammation is a walling off of the inflamed area with fibrin. So you end up walling off part of the part of the pancreas that is really inflamed, and it protects the rest of the pancreas, and it ends up being self-limited. And this is true most of the time. However, there are times when this downward spiral continues and spreads throughout the pancreas, and then we end up with all sorts of problems. So we'll talk about severe acute pancreatitis here. And what happens is we've got these proteases that are causing cell death, and one of the proteases that's a particularly bad actor when it's is a group of proteases called elastases. And this is bad because elastin is a protein that's very important in blood vessels, particularly arteries and arterioles. So we start to have a enzyme that breaks down the walls of vessels, and when we break down walls of vessels, we get bleeding, and so we end up with hemorrhaging. And it usually starts out with just a microhemorrhage. And then even worse than the hemorrhaging is when we have broken vessels, we also have pancreatic enzymes entering the systemic circulation. Of activated proteases and lipases. Well, amylases really don't cause much of a problem. It's the proteases and lipases that wreak havoc. And this leads to a systemic inflammatory response syndrome. And so we have inflammation throughout the body. This causes massive vasodilation and hypotension. It causes capillary leak and edema. Now, interestingly, the lungs are a highly vascular organ, and they're sort of first in line for venous return to the heart. So many of these proteases and lipases go directly to the lungs, and you end up with very severe ARDS. And in fact, the mortality of severe pancreatitis, 50% of the mortality is due to ARDS. And this is just because the lungs, first of all, are first in line from the pancreas, and second of all, they are more vascular than any other organ. Now, when we have systemic spread of enzymes, another one of the real bad actors is trypsin. And that's because trypsin is an enzyme that is designed to activate other enzymes. And some of the proteins that it activates are part of the inflammatory cascade and part of the coagulation cascade. So this is feeding into the SIRS very directly, and we also end up with microemboli, which can lead to multi-organ failure, otherwise known as multi-organ dysfunction. And it can also lead to DIC, where we use up all of our clotting factors and then we bleed. So those are the acute effects. It can also cause a number of chronic effects. For instance, the pancreas can sort of auto-digest itself and leak fluids into itself, and over time you can end up with pancreatic abscesses. You can end up with collections of sort of pancreatic enzymes that start to erode into a major vessel. Most seriously, an artery, and when you erode into an artery, then you create a situation where the pseudocyst can continue to grow and grow and grow, and if it ruptures, then you end up with a major hemorrhage. This can be treated with a embolization procedure, where you sort of block off the vessel with wires or beads. Now also, if you end up with a lot of necrosis in the pancreas and you kill off a significant number of the cells, you can end up with pancreatic insufficiency, in which you don't have enough pancreatic enzymes and pancreatic function to support digestion. You can end up with issues with poor fat absorption and steatorrhea. You can end up with poor protein absorption and malnutrition, and you also can do damage to the islets of Langerhans as well. And I've seen people that have had, sort of a very severe case of acute pancreatitis, or a, repeated cases of pancreatitis from alcohol abuse, that have done enough damage to their pancreas that they have made themselves into type 1 diabetics, because they no longer have significant insulin production. Okay, that brings me to an end of this video. Thank you very much for watching. And please, as always, please leave me feedback. And if you have any questions, please ask them in the comments, and I'll be glad to try to answer them. And if you'd like a quick and easy link to my channel on GI physiology and pathophysiology, I will put it here below. Thank you very much for watching.